Good afternoon. Today's topic of presentation is malignant salivary gland neoplasm. As the list of malignant salivary gland neoplasm is vast, we are going to see only important carcinomas. Before that, we are going to see the cell of origin from which the carcinoma arises. When the acinus is involved, it causes acinic cell carcinoma. When the intercalated duct is involved, it causes adenoid cystic carcinoma, epithelial-myoepithelial carcinoma, and when the excretory duct is involved, it causes Mucoepidermoid carcinoma, epidermoid carcinoma, ductal adenocarcinoma. So coming to the first malignant salivary gland neoplasm, that is Mucoepidermoid carcinoma, it composed of mucinous, intermediate and squamous tumor cells forming cystic and solid patterns. It is most commonly seen in children and young adults. The peak incidence is occurring second decade of life. It develops secondary to radiation chemotherapy during childhood. The most common site is parotid gland. Other sites are palate, submandibular gland, and other intraoral minor salivary glands. So, on gross, the tumor is soft to firm, circumscribed, or infiltrative mass with cystic components. On cytology, aspirates of low-grade tumor are mostly cystic and shows predominantly mucus and macrophages. Aspirates of high-grade lesions are more cellular, showing admixture of epithelial cell type typical of that lesion. On histologically, we can see in low-grade mucoepidermoid carcinoma are mostly cystic. Intermediate grade carcinomas are more solid and less circumscribed and shows a diversity of appearance including mucin extravasation. High-grade mucoepidermoid carcinomas display one or more of the following features, that is nuclear anaplasia, necrosis, increased mitotic rate, perineural and lymphovascular or bony invasion. The cystic oncocytic mucoepidermoid carcinoma can mimic Warthin tumor. Mucoepidermoid carcinoma may develop in Warthin tumors, and the sclerosing variant can be mistaken as sclerosing sialadenitis. Here in this diagram, the green arrow shows the mucous cells, the red arrow shows the intermediate cells, and yellow arrow shows the squamate cells or epidermoid cells. The rare oncocytic variant shows few squamate cells. The sclerosing variant shows dense hyalinizing fibrosis, and solid mucoepidermoid carcinoma are predominantly squamate and intermediate cells with subtle transition between these two components. Here in this diagram we can see a circumscribed tumor with clear cell composition, and here in this diagram we can see the oncocytic variant with the individual cells are eosinophilic, shows eosinophilic cytoplasm. On IHC, we can see the positivity for pancytokeratin, CK5, 6, P63, P40, CK7 and CK14. There is a strong staining for P63, and the presence of 11 translocation 11 and 19 is helpful in distinguishing oncocytic rich mucoepidermoid carcinoma from other neoplasms. The most common translocation occur in mucoepidermoid carcinoma are translocation 11 and 19 and Q21 and P13. The low-grade and intermediate mucoepidermoid carcinomas are less aggressive, whereas the solid variant are more aggressive, and it is cured by complete surgical excision. The 10-year survival rate for low-grade epidermoid carcinoma, mucoepidermoid carcinoma are 90%, intermediate is 70%, and high-grade is 25%. Coming to the adenoid cystic carcinoma, it is a slow-growing salivary gland malignancy composed of epithelial and myoepithelial neoplastic cells that form various patterns, including tubular, cribriform, and solidiforms. It is most commonly seen in 57 years of age, and the male to female ratio is 1.5:1. On grossly, the tumor shows grayish-white, unencapsulated and infiltrative mass of variable size. On cytology, aspirates shows high NC ratio, basaloid tumor cells surrounding a cellular matrix with cribriform pattern. In this diagram, we can see a poor matrix with basaloid cells, and here in this diagram, there is a monotonous basaloid tumor cells with high NC ratio, some of which are surrounding pale staining basement-like material. On histopathologically, it is the most recognizable architectural form is the cribriform pattern, and this is the cribriform pattern which shows nest of tumor cells interrupted by sharply punched out spaces filled with basaloid matrix. The tubular pattern is bilate tubules which show no true lumina. This is the solid variant where the tumor cells are separated by a fibrous septae. The adenoid cystic carcinoma, the perineural invasion is the hallmark of this neoplasm. On immunohistochemistry, the inner epithelial cell are positive for CD117 and peripheral myoepithelial cells are positive for P63 and SMA. Immunostaining for MYB and NFIB fusion oncoprotein shows the cribriform growth pattern. Prognosis of this tumor is 10-year survival rate is for 50 to 70%. There is a lymph node involvement is uncommon, but it is most commonly seen in solid variant. There is a distant metastasis occur in 50% of the cases. Most commonly, the lung is involved, after that bone, liver and brain. The tumor with tubular and cribriform patterns are less aggressive, whereas the solid variant are more aggressive. The radical surgical excision with or without post-operative radiation is the treatment of choice. The overall survival is poorer with a single modality. Now coming to the acinic cell carcinoma, it composed of cells with acinar features. It is approximately occurring 50 years of age. With female to male ratio is 1.5:1. Acinic cell carcinoma is the second most common salivary gland malignancy in children. It is more than 90 to 95% of acinic cell carcinoma occur in parotid gland. Macroscopically, the tumor is circumscribed, solitary nodule of varying size. Some are poorly defined. On cytologically, we can see the three-dimensional cluster of acinic cells with abundant delicate cytoplasm, low NC ratio, uniform round to oval nuclei with distinct nucleoli. Histopathologically, the tumor cells shows the acinar and ductal cells with variable vacuolated, clear, oncocytic or hobnail features, forming solid, microcystic and follicular pattern. The also shows the papillary cystic component. The acinar cells are large, polygonal with basophilic granular cytoplasm and round eccentric nuclei. The neural and stromal invasion shows the aggressiveness of this tumor. Although non-specific, OOG1 and SOX10 are immunopositive for acinar and intercalated duct cells. Immunonegativity for mammoglobin, which is useful in distinguishing it from the secretory cell carcinoma. In this diagram, we can see the serous acinar cells. In this diagram, we can see the serous acinar cell with microcystic spaces. Here in this diagram, we can see a clear cells plus serous acinar cells, and here we can see the follicular growth like pattern. In this diagram, we can see the dog1 stain which stain most of the acinic cell, and prognosis of this tumor is generally it is not so aggressive tumor. It can metastasize to cervical lymph node and lung. It is a rare tumor. It is most commonly seen in parotid gland. On grossly, the tumor is small, unencapsulated, and cystic. The low grade on histopathologically, the low grade tumors are mostly cystic with cribriform and papillary pattern, and the intermediate and high grade tumors are shows the marked to moderate to marked cellular atypia, numerous mitotic figure are seen. Here in this diagram, we can see the cystic spaces lined by epithelium with partly rigid structures. The arrow indicate a neighboring invasive carcinoma. In this diagram, we can see the mixture of cyst and smaller duct, as well as florid and atypical ductal hyperplasia. In this diagram, we see a large duct lined by neoplastic cells with micropapillary features. Now, coming to the salivary duct carcinoma, it is also known as high-grade ductal carcinoma. It is aggressive epithelial malignancy which resembles high-grade mammillary ductal carcinoma. It is mostly male predominance with 6 to 7 decades of life. It is most commonly seen in parotid gland, and clinically it is rapidly growing tumor commonly associated with facial nerve palsy, pain, and cervical lymphadenopathy. Macroscopically, the tumor is varying in size and infiltrative. On cut surface, we can see a grayish-white area with occasional small cysts and foci of necrosis. On cytology, we can see aspirates are cellular. Sometimes it shows the papillary configurations and flat sheets of epithelial tumor cells with necrotic background. Histopathologically, the tumor has a striking resemblance with high-grade ductal carcinoma, and it shows the Roman bridge-like features. The lymphovascular and perineural invasion is common. Here in this diagram, we can see a sarcomatoid variant of this tumor, and here in this diagram, we can see a mucin legs, and on the right side, mucin legs in the right side, and on the left, we can see a conventional salivary duct carcinoma component. So, as we discussed, it is the cribriform structures shows the Roman bridge-like appearance. In this diagram, we can see irregular glands and cords which shows the desmoplastic reaction. Here, we can see a pleomorphic nuclei with coarse chromatin, and here we can see a micropapillary pattern. In this, the tumor nests are separated by the vacuolated spaces. On IC, it shows the immunopositivity for androgen receptor, which is a nuclear stain. And here we can see the diffuse and strong membranous immunostaining for ER, BB2 and HER2 in 20 to 30% of the cases. Salivary duct carcinoma is one of the most aggressive malignant salivary gland tumor with frequent local recurrence and regional lymph node and distal metastasis. Coming to the myoepithelial carcinoma, it is composed of neoplastic myoepithelial cells with an infiltrative growth. It occurs in any age with no sex predilection. It is most commonly seen in parotid gland. Clinically, it shows a painless mass with a recent rapid increase in size. Facial weakness and paresis may occur when the facial nerve is involved. On grossly, the tumor is unencapsulated, soft to firm. The cut section is grey to tan white with occasionally hemorrhage with cystic degeneration and necrosis. On cytologically, we can see a aspirate smears showing a mixture of spindle cells, epithelial cells, plasmacytoid cells in a small group of large fragments. Nuclei can be round to oval with variable cytoplasmic features. Now, on histopathologically, we can see a clear cells with myxoid matrix. In this diagram, we can see a myxoid cord-like myoepithelial tumor pattern, and here we can see a nodules which is separated by dense fibrous stoma. On IHC, it positive for P63 and P40 and negative for S100, SOX10 and DOG1. It shows a distant metastasis rather than regional lymph node. Distant metastasis mostly occur in the lung. One-third of the cases are cured with surgical resection and one-third experience metastatic and progressive disease. Coming to the epithelial-myoepithelial carcinoma, it composed of biphasic arrangement of inner luminal ductal cells and outer myoepithelial cells. It is occur in 6 to 7 decades of life with slightly female predilection. It is most commonly seen in parotid gland followed by submandibular gland. It typically presents as slow-growing painless mass. Macroscopically, it shows a multinodular firm to rubbery mass with pushing borders. It is submucosal and 40% of the cases shows overlying mucosal ulceration. On cytology, we can see a tumor cells with cluster of dual cell population, that is pale myoepithelial cells and smaller eosinophilic ductal cells. Net nuclei are common and stoma is scant with some hyaline globules. Histopathologically, we can see a multinodular pattern. Outer abluminal polygonal cells, myoepithelial cells are classically clear, shows clear cytoplasm, and growth, solid overgrowth and necrosis may be present. Perineural invasion is common and vascular invasion is less. Low molecular weight cytokeratin are strongly positive for ductal component, and myoepithelial markers are SMA, HHF35, P63, calponin highlight the abluminal compartment. S100 stain both myoepithelial and ductal component of to variable degree. On immunohistochemistry, it is P63, P40 and S100 positive and SOX10 DOG1 negative. Epithelial myoepithelial carcinoma is usually indolent, but local recurrence is not uncommon. Lymph node and distant metastases are rare. Here in this diagram, we can see a multinodular septate growth pattern with dense sclerosis. Here in this diagram, we can see a high-grade transformation of both luminal and abluminal cells. In this diagram, we can see tubular to cribriform growth pattern, and here we can see a tubular growth with clear polygonal abnormal cells with eosinophilic luminal ducts. Coming to the carcinoma X pleomorphic adenoma, it is an epithelial or myoepithelial malignancy. It developed from the primary or recurrent pleomorphic adenoma. It can be either purely epithelial or myoepithelial. It shows 3 to 6% of all salivary gland tumors and comprises 12% of all salivary gland malignancies. It is most commonly seen in 6 to 7 decades of life. That is 1 decade later than the peak incidence of pleomorphic adenoma. It is most commonly seen in parotid gland. Clinically, it presents as rapidly growing mass with a pre-existing long-standing mass of pleomorphic adenoma. Now coming to the pathogenesis, here how the pleomorphic adenoma is converted in invasive carcinoma. Here the precursor lesion shows a luminal cells and which forms a duct and abluminal cells which is supporting cells. When there is abnormal proliferation within or between the existing pleomorphic adenoma, it causes nuclear enlargement, prominent nucleoli and chordate. And when there is a breach in the pleomorphic adenoma capsule by carcinoma cell, Carcinoma cell, it is measured in and in widely invasive, there is extending into the tumor cells extend into the gland and often soft tissue. The pleomorphic adenoma component may be hyalinized. So coming to the macroscopy, as many as 64% cases are infiltrative, the residual pleomorphic adenoma component shows grossly visible in most of the cases, usually as sclerotic or calcified nodule. On cytologically, we can see a smears typically shows features of pleomorphic adenoma or a high-grade adenocarcinoma. Histopathologically, there is a high-grade, it shows the high-grade adenocarcinoma. The intracapsular carcinoma constitute carcinoma confined within pleomorphic adenoma. Here we can see a hyalinized pre-existing pleomorphic adenoma with a 3 mm focus of carcinoma extending beyond the pleomorphic adenoma capsule. Uh, it is HMG-A1 positive, which is highly specific and low sensitivity for carcinoma X pleomorphic adenoma. It is the aggressive malignancy. Local and distant metastasis occur in 70% of the cases, and 5-year overall survival rate is seen in 25 to 65% of the cases. Coming to the poorly differentiated carcinoma, it is a primary carcinoma showing large and small cell type with or without neuroendocrine differentiation. The median patient age of presentation is 64 years and male to female ratio is 2.4:1. It is most commonly occur in parotid gland. Clinically, it shows painless mass, some present with facial nerve pulse. Macroscopically, the tumor is poorly defined, firm, white mass measuring 2 to 5 cm. The aspirate shows a small cell carcinoma characterized by tumor cells with high NC ratio, nuclear molding, and scant cytoplasm. There is in this diagram we can see a coagulative necrosis, tumor cells with nuclear molding and scant cytoplasm. Histopathologically, both small cell carcinoma and large cell neuroendocrine carcinomas are high grade. On IHC, the tumor cell express synaptophysin and chromogranin. The small cell carcinoma shows perinuclear dot-like positivity for pancytocratin and CK20. The 2-year survival rate is for small cell carcinoma is 56%. Here we can see a positive synaptophysin immunohistochemistry. Coming to the lymphoepithelial carcinoma, which is a grossly, the tumor are well circumscribed and lobulated with firm tan white cut surface. Cytologically, the aspirate shows the showing the undifferentiated appearing epithelial cells and in the lymphoid background. Here we can see the undifferentiated uh, epithelial cells in the lymphoid background. The In this diagram, we can see our nodules with circumscribed tumor mass consisting of sheets and a poorly defined nest of eosinophilic tumor cells in dense lymphoid stroma, mimicking involvement of parotid lymph node. In this diagram, we can see puzzledly arranged tumor cells with poorly defined borders, vesicular chromatin, and prominent nucleoli, dense lymphoplasmacytic inflammatory infiltrate and apoptotic bodies. Here we can see in situ hybridization for Epstein-Barr virus encoded small RNA shows extensive strong nuclear positivity. Coming to the squamous cell carcinoma, it is a rare carcinoma. The majority of the published cases shows squamous differentiation of other salivary gland carcinoma or metastatic squamous cell carcinoma from dermal primary. Here, the tumor is firm and infiltrative. In this diagram, we can see the squamous dysplasia and transition from the dilated salivary duct, which shows a primary salivary gland origin. The most of the parotid squamous cell carcinoma derive from the primary cutaneous squamous cell carcinoma, most commonly through metastasis. Coming to the oncocytic carcinoma, grossly, it shows a grayish yellow, irregular but well-defined mass. Histopathologically, we can see a large polyhedral cells with abundant granular eosinophilic cytoplasm and round to oval vesicular nuclei, forming organoid nests and trabeculae with infiltrative features. So, on the tubular structure, nuclear pleomorphism and vascular invasion we can see in this tumor. The differential diagnoses are the oncocytic variant of Mucoepidermoid carcinoma as well as the salivary duct carcinoma. So, how can we differentiate from these tumors? In oncocytic Mucoepidermoid carcinoma, we see the features typical of mucous cells, which is not seen in the oncocytic carcinoma. And in salivary duct carcinoma, mimic oncocytic carcinoma but exhibit other patterns, especially comedonecrosis. So, comedonecrosis is seen in salivary duct carcinoma and not seen in oncocytic carcinoma. The rarity of entity precludes the assessment of its biological behavior. The complete excision is generally curative. So, in this diagram, we can see the invasion into the surrounding adipose tissue. We can see the invasion the surrounding adipose tissue with multinodular architecture. In this diagram, we can see the multinodular architecture which invade into the adipose tissue. In this diagram, we can see the abundant granular eosinophilic cytoplasm and vesicular nuclei with prominent nucleoli are arranged in alveolar nests accompanied by luminal structures containing eosinophilic substance. There is a mild nuclear pleomorphism. Now coming to the lymphoma, it comprises 1 to 1.7 to 6% of all salivary gland neoplasm and 6 to 26% of all extranodal lymphomas in the head and neck region. It is most commonly involve the parotid gland. The age of presentation is 57 to 63 years of age. Marked lymphoma is most common primary salivary gland lymphoma. In this diagram, we can see the tonsil marked lymphoma. The normal lobular architecture of the tonsil has been effaced by a dense and expansile sheets of lymphoma cells. Among these, a diffuse large B-cell lymphoma has a more aggressive clinical behavior. Now, coming to the extranodal marginal zone mucosa associated lymphoid tissue lymphoma, where it is occur in head and neck region, second common frequent site of marked lymphoma following the gastrointestinal tract. It is a most common type of lymphoma in salivary gland with age of presentation is 58 years. It occurs due to chronic inflammation related to infectious diseases or autoimmune disorders or de novo formation of lymphoid tissue in organ, otherwise devoid of mucosa associated lymphoid tissue. Coming to the next salivary gland, malignant salivary gland neoplasm, that is polymorphous adenocarcinoma. It is approximately occur in 60% of the cases. It occur. It in generally involve the palate. It is the firm, circumscribed, unencapsulated, yellowish tan, lobulated nodule of variable size. Histopathologically, we can see a main microscopic architectural pattern which is lobular, trabecular, microcystic or cribriform as in adenoid cystic carcinoma or solid and papillary cystic. Here we can see the historiform pattern. In this diagram, we can see the cribriform variant of adeno carcinoma, and here the tumor, we can see the tumor is submucosal, well circumscribed nodule. Coming to the next to salivary gland neoplasm, that is xyloblastoma. It is a rare primitive basaloid salivary gland tumor of infancy with marked resemblance to salivary gland analog structures and uncertain malignant potential. It is most commonly seen in parotid gland. The xyloblastoma, the tumor forms the sheets of basaloid cells with focal ductal differentiation. The tumor cells are uniform without mitotic figure or pleomorphism. Now, we generally follow the TNM classification for reporting the salivary gland neoplasm, malignant salivary gland. Now, the grossing of the malignant of the salivary glands, uh, in our department, we can receive the samples, that is parotid gland, submandibular gland. The type of specimen are superficial pyridectomy specimen for small lesions involving superficial lobe, and total pyridectomy specimen for advanced tumors, and usually include resection of facial nerve. In submandibular gland, the entire gland resected along with variable amount of adjacent tissue. So, in grossing, we first identify the type of specimen and extent of surgery. We weight the specimen, record the dimensions, external surface which is smooth or bossolated or irregular in the external surface of the specimen entirely, slice or breadlobe the gland entirely, and identify the tumor, note its size, appearance, extent, presence or absence of capsule or relation to the resection margins. Look for any extraparenchymal extension of the tumor and note it. Identify and note down involvement of any other adjacent structures including skin, bone and ear canal. Describe adjacent parenchyma including color, appearance, fibrosis, dilated duct or calculi. Identify the lymph node if any. Section to be submitted are tumor with closest in margin, adjacent salivary gland and lymph nodes. So, this is the CAP protocol. We generally follow the CAP protocol for histopathological reporting, which include specimen designated or containing parotid, submandibular, sublingual gland. The specimen not included or precludes, not required for accreditation purposes are biopsy, primary resection specimen with no residual cancer, and cytological specimens. This is the this is the immunohistochemistry, where static duct are ASCL3, CK14, CKIT, CD133 and CD24, CD49F, SCA1, MUA, SHI and CD29 positive. Intercalated duct are ASCL3 positive. Basal cells are CK5 positive. Excretory duct are ASCL3, CK14, CKIT, CD13, CD24, CD49, 491, SCA1, MU, SACHI1 and CD29 positive.